our next item on the agenda, which is 6.6, 10:15 a.m. item, consideration of presentation on the organized delivery system, 1115 demonstration and 1915B waiver for substance use disorder treatment services, and B, approve joining the organized delivery system. And with this, Director Metcalf will be presenting this item on behalf of Behavioral Health Services, along with others. All right. Will there be anyone else joining us on Zoom as well, or? Okay.
Maybe. Elise Jones, our administrative deputy director, could not be here, but she may.
Okay, and then I see Mark Bontrager
Yes, he
and
will be joining us.
Okay.
Well.
As will Jennifer Kent.
Oh,
I,
yes.
I see her hand raised, and so
Good.
yes.
Why don't you guys sit there?
And with that, if we can add them to the, yes, there you go. He's adding them to the list so that way they can be part of the. All right. And then we'll give the floor to you.
Yes, thank you, Mr. Chair, and members of the board. My name is Todd Metcalf. I'm the Director of Lake County Behavioral Services. You have heard us talk about this 1115 waiver over the last few months, or maybe even longer than that, because this is a discussion that's been going around for many years since I've been in this position. So today, I have our Substance Use Disorder Services Administrator, April Gambra, with me, along with our esteemed Mental Health Advisory Board Chair, Julie Colfax, who will help us talk through the Drug Medi-Cal Organized Delivery System for Substance Use Disorder Services. We have recently facilitated a few stakeholder meetings and surveys over the last couple of months to help determine which organized delivery system we should implement. There are two models, which you will hear about shortly here, that will be outlined by two guest subject matter speakers that can speak very well to both of those two models. Julie Colfax has graciously volunteered to help facilitate this discussion, not voluntold, but volunteered to help us walk through this. And she will also be sharing the feedback that we received from the stakeholders from the meetings and surveys that we facilitated. So April and I are here to support. I believe Elise Jones, our administrative deputy director, is also in here via Zoom that could, jump in as needed. So Julie, are you ready?
Yes, I think so.
Great. Thank you.
The microphone.
Okay. I speak kind of loud, so I don't want to overpower it. Yes, my name is Julie Colfax. I'm a licensed marriage and family therapist and chair of the Mental Health Advisory Board. I participated with Lake County Behavioral Health Services in inviting input from over 92 different invitees directly to our 4 stakeholder meetings, where we had some wonderful discussions about how the DMC ODS works and what the different options are and how it looks different from our current state plan. I would like to provide that information to you today at the end of the discussion about what those differences are and what the benefit is toward going with the DMC ODS over the current plan, which I know our folks will be providing from the department. But we did have 4 different stakeholder meetings during which representatives from more than 10 different agencies, local stakeholders, and community members participated in discussions along with the Mental Health Advisory Board, and I know some of the supervisors attended those as well. And so I will follow up the presentation that gives you information about it with the voice of the stakeholders.
Thank you.
We'll hand it over to...
Who's going first?
I believe. Good morning, Chair and members of the board. April Gambra, Lake County Behavioral Health. Todd previously announced my role with our department. I believe we have Jennifer Kent and we have Mark from Partnership. So Jennifer Kent is the ex-director of Department of Healthcare Services. So she helped facilitate and pave the way for the original 1115 drug Medi-Cal expanded delivery system. So she comes with a immense amount of knowledge, and so we've asked for her to be able to present that model. And then we also have Mark, and I do not want to try to pronounce his last name. He is I believe, the director with the Partnership Healthcare Plan. He will also provide an overview of that model, the regional model. And so I believe we're going to go ahead and start with Jennifer Kent, if she's ready.
Great. So first off, can people hear me?
Yes.
Okay, great. So thank you so much for allowing me to present to you. As April said, I am in some cases one of the people to blame or credit with the creation of the drug Medi-Cal organized delivery system program in California. So I just want to provide some kind of very quick overview about the history of how you as a county are kind of facing a couple of different options today. So pre-2015, there were very few options for patients in Medi-Cal to get any kind of treatment for substance use disorder. It was a very limited benefit. It was, it had some very public problems with fraudulent providers, most notably down in Los Angeles. And so as a result of those unfortunate occurrences, it gave the state an opportunity to re-envision the way that we delivered substance use disorder services to residents of the various counties. And so we asked the federal government for a waiver to allow us to both increase benefits, but to also waive certain federal rules that have been in place for many, many years and prevented state Medicaid programs from receiving matching funds for certain types of things like residential treatment. So, California has a requirement in federal law that you have to maintain statewide access to drug Medi-Cal services approved in the state plan. That's basically California's contract with the federal government to provide Medi-Cal services. And by maintaining that contract, you continue to be able to draw down, hundreds of millions, if not billions of dollars in federal funds. So as you think about your options that you're going to be thinking today in terms of which delivery system you want to choose, I really want to stress that there are significant federal funds that will flow to you as a county opting into either system that you so select. And then making it more complicated for people that are not well versed in this program. Under the 2011 realignment deal struck between the state of California and the counties, the state of California has agreed to support county expenditures when benefits, services, or eligibility levels change above the time in 2011 when the deal was announced. So the implementation of the Affordable Care Act, for example, when we allowed and expanded Medicaid to single childless adults, that federal matching dollar is matched with state general fund and not county funds. And so that's also a very important component when you think about going into the organized delivery system. And I'll have an example maybe that I'll refer to a little bit later about another county where you can really see the magnification of those federal funds versus the county funds that are being much more efficiently used. There are a lot of compliance challenges with both running your current existing program as well as a new program under the organized delivery system. So I don't want to dismiss that. And I know that your staff has been very mindful of the fact that there are contracting requirements, there are oversight and compliance issues that need to be managed. There are data and privacy and security factors that always need to be taken into account. And then in this new world order under the organized delivery system, there are requirements such as network adequacy. You have to do a provider directory. There's a very kind of rigorous appeals and grievance process, continuity of care. And so smaller counties are sometimes a little bit taken aback by the nature of these requirements because they are more than what you are doing now. I'm not saying that that's an impossibility or it makes it less likely to choose that option. I'm just saying that smaller counties, again, given sometimes smaller staff and less familiarity, are taken a little bit, they're a little bit stunned by how much more compliance has to be followed. And I come from a small county by way of background. So I grew up in Mariposa. So I've got the small county experience working for me. The difference between what you provide now as a county and what you will provide under the drug organized delivery system is pretty significant. I mentioned the biggest one, which is residential. I think that the standard benefits, under the drug Medi-Cal program today are outpatient, intensive outpatient, detoxification, narcotic treatment services, and perinatal residential treatment. That's the bare minimum of what state plan counties such as yourself have to provide. If you go into the drug Medi-Cal ODS system, you are not only doing all of those, but you are adding partial hospitalization, withdrawal management, recovery services, case management, physician consultation, additional medication-assisted treatment, and then residential treatment, which, as I said before, was really kind of one of the biggest changes that the ODS system brought to this benefit. I want to stress that counties voluntarily opt into this waiver and into this benefit. So you as a board of supervisors are in no way being forced by the state to do this. I think this is very much at the county's option, but also I think, speaking from where I used to sit at the department, really want to kind of highlight the fact that patients under this optional program have so many more treatment options and availability to them that is otherwise not. And so I think it was always the intent of both the state and the federal government, as well as the counties that have gone in first, is that this is something that is really about working within local jurisdictions to find solutions for populations that have been traditionally left out of more robust treatment. Obviously, I know that there was conversation about this in the stakeholder meetings that I was able to attend, is the local provider networks are certainly established in both your county and in some of the surrounding counties. And I think that, the partnership option or the county-led ODS option require you to have to contract with providers that are outside of your county borders. And that would be true no matter which option you choose. But I think that, there's certainly an immediate base of providers that you have been working with that would be a part of this new ODS model, whichever one you choose. Obviously, there are new evidence-based practices and assessments that you have to do for patients. We are attempting under this ODS model to increase your local control and accountability for these services, right? Because the contract that you would enter into would be between you, the state, and the federal government. So they are kind of three-way contracts. And obviously, you would still retain the ability under the ODS model to kind of propose and negotiate your own county-specific both providers as well as rates. Before I kind of finish and take questions, I wanted to give you an example of a small county. It's obviously bigger than Lake, but Marin County, and I liked to use them when I was trying to talk to other counties about ODS. They, in the first year, they were one of the first counties to implement the ODS program on their own. And in their first year of operation, their total expenditures for services was $3.9 million total. So all services for those patients that they treated added up to $3.9 million. The federal funds that were drawn down for those services was $3.1 million. And the state general fund added another $395,000. So if you're really good at math, you're like, wow, it doesn't sound like Marin County put in that much. And you are correct. Marin put in about $457,000 and served 825 patients total, who used $3.9 million worth of services, but the county's share was only $457,000. And so that is where I think the magic, right, of running a really kind of aggressive program that is built heavily leveraged on federal funds, using the state general fund to the advantage and preserving as much as possible the county funds for other obligations and other programs, other wraparound services. Really wanted to kind of just demonstrate that that is the kind of magnification that you would see that I talk about when you talk about federal funds. And then we get to the partnership model. So we implemented the ODS program in the state of California, and counties opted in. Some came in first phases, some came in second phases. And then there were a few counties, all small northern rural counties, that approached Partnership Health Plan and said, hey, we would like to have you, Partnership, operate this on our behalf. And so I left the state and the department before that was implemented. So I will obviously defer to Mark on the details, but essentially there was an interest and helping from Partnership, understanding that these smaller counties didn't want to recreate the wheel. 7, or at the original time, 8 different wheels didn't need to be created. And so Partnership stepped in and said, we will do this on your behalf and handle the compliance and the provider contracting in the network. I think what I would like to say, as you kind of weigh the two different options, there are obviously compliance issues, right, that you need to be mindful of. Those are not insignificant, and corrective action plans from the state either come to the county directly to be handled, or in some cases under the partnership model, they go to Partnership, and then counties have to kind of work under that larger kind of structure that the plan has done. I think that you should always be mindful of the fact that no matter which option you choose, the county cannot shirk its fiscal obligations, right? You, under the realignment deal and under Proposition 30, as a county have agreed to pay for certain services for both pediatric and adult populations. And so those obligations do not go away under either model. And I think that, Mark can obviously, if you have questions about the financing under the partnership model versus the financing under a county-led ODS model, ultimately, they do require you to be paying providers and being reconciled to cost, which is just how you are set up as a county today. I think that, there is something to be said about making sure that you don't break any of the existing either services or provider capacity that you currently have in your county. You have a rich set of providers, actually very well-established providers today, But you need to be mindful that in a change of any kind with new contracts, different financing arrangements, referral patterns, and making sure that your residents are not necessarily having to travel further than necessary. You just need to think about some of the downstream impacts that even if a patient goes into a residential placement, say down in Sacramento or down in the Bay Area, you want them to be able to, upon completion of their treatment down there and stepping out of that intensive treatment into more regular outpatient services, you need to make sure that they are being kind of repatriated back to their community where their support network or their family or their jobs are, and that they're not necessarily being placed out of county and having a hard time getting back. And so I would just say that those are some of the kind of operational policy issues that I wanted to make sure that you thought about. And then lastly, I will just open it up for questions. I know I tried to be very high level, but if you have questions, I'm happy to entertain them now or wait for the larger presentations to complete.
Yeah, we'll continue forward and then ask questions. Yeah. So with that, is that the next person, is that Mark? Yes. All right, Mark.
Thank you. I believe we submitted a PowerPoint. Can that be put up?
Yes, well, I checked with Matthew. He said he always comes to the rescue.
Okay, great. Yeah, well, thank you very much. First and foremost, I want to thank Todd and his staff in April and the Lake County Behavioral Health team. First of all, for endeavoring to take this on and to do it so thoughtfully. I know they've had a series of stakeholder groups. I can think of no better person to consult with than actually Jennifer Kent on this matter. So the thoughtfulness in which the behavioral health team has taken this on, I think is really excellent. So I just want to start with that. And then can we go to the next slide? So just to level set real quickly, Partnership Health Plan is the managed care plan, Medi-Cal managed care plan for 14 Northern California counties. We're a nonprofit, a public nonprofit. We were created by each Board of Supervisors in those 14 counties where they voted to create a county organized health system in order to improve healthcare access by their Medi-Cal residents in their county and to create a stronger network of care. As it relates to Lake County, I believe it was about 2013 when you guys joined Partnership Health Plan. Next slide. I'm gonna skip this slide because I think Jennifer did an excellent job describing what a drug Medi-Cal organized delivery system is. So let's go to the next slide. So what is the regional model? So as Jennifer indicated, counties can choose to opt into this enhanced drug treatment benefit. And in our 14 counties, 3 of them have on their own. That's Marin, Napa, and Yolo. And then these 7 counties here on this slide are the ones who decided to join the regional model with Partnership. And what the regional model really is, it is a 3-way agreement between the state, the counties, and Partnership Health Plan. And that 3-way agreement really defines what our roles and responsibilities are. Next slide. So in this agreement, Partnership Health Plan really bears a lot of the administrative burdens for the provider contracting, the screening and enrollment, the credentialing, the network management, utilization management. We manage a 24/7 access line. We endeavor to do all the compliance-related activities. If there's corrective action plans or audits, EQRO audits, we create the grievance and appeal system that we manage, and then we do those annual financial reconciliations that Jennifer alluded to. Meanwhile, just to say real quickly, the counties, their responsibility, quite frankly, is to oversee us, to ensure that we are meeting those obligations that they have delegated to us. We're meeting those responsibilities. And they work in partnership with us to ensure that collectively we're meeting all those requirements. So that's kind of how we delegate the responsibilities in this regional model. Next slide. So Jennifer did describe the financial model, and when it comes to federal Medicaid land, it's not an easy one to describe, but she did an excellent job. What I want to do is just kind of briefly describe how it works within the regional model, and then on the next slide, when we get there, I'll actually show you an example of that, try to walk through one. But what we do for the regional model and how it works financially is we work with each county to look at their historic utilization and their anticipated utilization, and we come up with what we believe will be the average cost per user per month. This is just our best guess of what we think the costs will be. And then at the end of the year, we will reconcile to see how closely we hit it. It could be over, it could be under, but that's how we work with each county to ensure that we come up with what we think the actual costs will be on average per user per month. And so we invoice the county after we've received a claim from a Medi-Cal beneficiary from that county. We will then invoice the county. The counties will then pay that invoice, and then I'll describe that in further detail. But the invoices will include really three components. It's the per user per month cost, which is our expected actual costs. It will also include, if it is a residential treatment, it will include a room and board cost. And the reason why that is segregated out, I'll get to in a moment. And then lastly, a 6.7% admin and quality improvement line that we as Partnership Health Plan charge in order to cover our administration and participation costs, as well as some of our QI activities. So go to the next slide. Okay, so this is where I'm going to attempt to actually run through an example of this fiscal model. And if you're not already scared, I'm going to do my best to keep you locked in here. But let's just run through an example. So let's assume this is Lake County and you are part of the regional model. You have a member. Let's call her Wanda. She's been couch surfing for a few months, maybe doing crystal meth. She had a friend that she just saw overdose, and so she is now quite motivated to get treatment. And we want to really take advantage of folks when they're in that moment where they are motivated for treatment. So we have this no wrong door approach, where Wanda could call our access line 24 hours a day, 7 days a week, 365. Or she could walk into one of our county programs, or she could additionally walk right straight into the door of one of our providers. So there's no wrong door. If she's motivated and she wants to seek services, she can go any of those three ways. So let's just assume in this situation that she is choosing to walk into the door of a residential treatment provider, say there in Lake County. We'll call them Brighter Days Residential Treatment. They do a quick screen with her. They identify that she does indeed need residential treatment. And so she embarks upon treatment there at the Brighter Days Residential Treatment Facility. At the end of the month, that treatment facility submits a claim electronically to Partnership Health Plan. We, in turn, were obligated to pay that claim within 30 days. They're a contracted provider, so we pay it. At the same time, we at Partnership identify that Wanda is a Lake County Medi-Cal beneficiary. So we go forward and invoice Lake County that per user per month that we have already agreed to, plus the room and board cost, because this is residential treatment, and then that 6.7%. The county in turn then pays Partnership that money, and then Partnership, we submit those claims to the state of California, their short oil Medi-Cal system, for review and approval, essentially. And basically, the state is looking to make sure that Wanda is an eligible beneficiary, that provider is a contracted eligible provider, and the service provided was an eligible service. And so once the state actually approves that, there's this thing that they call a certified public expenditure, where they ask Lake County, did you indeed pay this per user per month invoice? And Lake County says, we certify that we made a public expenditure. And so the state submits that claim to the federal government. And as Jennifer indicated, this is the beauty of it all. Depending on who Wanda is, And I'll give you a few examples. If Wanda is a Native American or a tribal member, the federal government will provide 100 cents of every dollar spent on that PUPM. If she is an expansion member under the Affordable Care Act, between the state and the feds, it's nearly 100 cents of every dollar of that PUPM. If she's a traditional Medi-Cal member, a mother with dependent kids, poor mother with dependent children, it might be 50 cents on the dollar. That money then returns back to Lake County. So what we've seen with our 7 counties in the regional model, on average, that per user per month, about 75 to 80 cents of the dollar spent are fronted by the county gets returned by the Fed and the state. And as Jennifer said, that's the secret sauce of trying to bring services in this arena, is really to lean on the federal participation rate. And just to say a few other things, that room and board rate, the federal government does not reimburse for room and board, so that's why we segregate that out in our invoicing, just for simplicity. If you can believe that this is actually simple, we tried to make it simple. So that is kind of the fiscal model and how it works in our regional model. I will say one other caveat, just to further confuse this. In 6 of our 7 regional model counties, the counties are actual outpatient providers as well, so they can actually fill 2 boxes here, both as an SUD provider and as the county who's being invoiced. So, next slide. So one thing the state does is they survey every year. They call treatment perception surveys, the client surveys of folks who participate in the drug Medi-Cal services across the state, basically asking if they're satisfied with services, was it convenient, do they feel respected, was it culturally appropriate, etc. It's compiled by an external firm, Behavioral Health Concepts in UCLA. This is just what we just received recently from them. And I'm happy to report for the regional model, on every measure, we outperform the state average. And I must admit that has very little to do with Partnership Health Plan. It's more of a reflection of our provider network, because this is really the treatment perceptions of our members and how they were treated by our providers. So very proud of our providers, even our county providers, to get that high level of satisfaction back. Next slide. So real quickly, we just wanted to show you, the state calls it penetration rates. I think a better way to really rename that is utilization rates. So if you want to look at what the utilization rates are by age compared to statewide, our regional model compared to statewide, you can see for adolescents, we're just a skosh under the statewide average, and several of the other areas were over. Our overall utilization rate is 1.56 compared to just over 1 for the statewide average, which is, I think that's great that we're a little over the state average. I believe we know that the need and the demand is quite higher than that, but just wanted to show you that. Next slide. And this is really utilization rates by race and ethnicity. You can see that amongst whites, we have the highest utilization rates, then second to Native American. On average, it's generally over the statewide average. At first blush, you'd say we should feel good about it, but if you really want to be critical here, I think one has to ask the question, why aren't all different demographic groups as high as the utilization rates as the white group? So I think there's more to be done, and there's more that we need to do around this. Just an FYI. Next slide. And then these are the different categories. As we said, the ACA, as you can see, there are nearly 4,000 utilizing members. About 2/3 are that expansion population or the Affordable Care Act population. And that's how we really get to that nearly 75 or 80 cents of the dollar coming back to the county. It's really based upon these aid codes and their penetration rates. Next slide. And then these are the types of services, as Jennifer indicated, there's a whole continuum of care from outpatient treatment to more significant and acute withdrawal management, residential, et cetera. And you can see that the regional utilization rates, our regional model, compares pretty similarly to the statewide average. And that's really how we can come up with a per user per month rate that pretty near hits the target, because we have expected utilization that we can go off of. Next slide. I guess just lastly, I want to say at Partnership Health Plan, our goal here is that Lake County will take on the task to ensure that Medi-Cal members in Lake County will have access to the enhanced benefit under the ODS model. And we support it whether Lake County decides to do it on their own, like 3 of our counties, or if they choose to join partnership on the regional model. Our interest here is just to ensure that more of our Medi-Cal members are getting those enhanced access to those enhanced benefits. Thank you.
Thank you, Mark. And is there a follow-up from, yep, there we go.
If there's no questions for Mark, I'd like to report a little bit on the information that was provided by the stakeholders at the 4 meetings we've had. As I mentioned, we invited 92 participants directly via email to the various stakeholder meetings and asked them to participate in surveys that were distributed as well. I think it's really important to point out that this isn't an opinion of the Mental Health Advisory Board, but really just a reflection of the data that we collected and the input from the stakeholders. So what I'm offering to you today isn't our opinion about what should happen, but only to reflect the data that we collected and that the behavioral department collected, because they were the ones sending out the surveys as well. I participated in making sure the distribution was out there, but the information came back from them. And really in the final numbers, it comes down to our final survey with 28 participants responding to the survey. 90% were in favor of working with partnership in the expanded service model. One note that I found very important with all of the discussions we've had and all of the information, it was quite a bit to handle, and I think many of us are still a bit confused about some of the aspects. But one of the things I found was very important is that our people are being taken care of. They're getting services. What this really does is ensures that Medi-Cal pays for more of the services that are already being provided. Is that to say that we're catching every single person who asks for help? No, there's a lot of different factors that come into play with that. Their actual readiness, yes, anybody can have a scare and decide they want services today. Does that mean that they're going to participate in them tomorrow? Not necessarily. But I think the really important point with the whole thing and the reason to really look at opting into the DMC ODS is actually the fact that the federal government and the state government will actually be reimbursing more of the services that we are already working so hard to provide to the clients and the people in our county. Which then, of course, allows us to provide more services with the funds that are available countywide. And so I think that's a really important piece that really stuck out to me throughout our conversations about this. I think it's also really important to point out that of the 28 people who replied to the survey, 13 of them were community or contract provider staff. So half of the people who responded were actually providers in our community, many of whom do already have a relationship with Partnership Health Plan, either through their current provision of services for other counties, because some of our agencies in our county are providing services to other counties as well, and for their medical services, because this DMC ODS is specific to the alcohol and other drugs services, the substance use services. So that is over 4 meetings and multiple hours of reviewing videos and making a list. I actually have a 35-page document with every comment in it. I didn't think you guys would appreciate having that, but I'm happy to send it out to you if you do. But that is a pretty quick summary of the conversations we've been having.
Thank you, Julie. Are there any questions about the presentation or to any of the presenters? Supervisor Sabatier?
So, sorry, first question is, are we waiting to talk about the 1915 waiver? Because I know we've been talking about the 1115 waiver right now, but on the agenda, it's both. What's the difference is kind of my question that I'm looking for. I know one of them is specialty mental health services, and the other one is drug, Medi-Cal, ODS. Just kind of curious as to, are we being asked to make a decision on both waivers today, and what is the difference between both waivers, as I believe we've only gotten information on the 1115?
This is specific to only substance use disorder services. And April, I don't know if you want to weigh in on that, but this has nothing to do with, well, I shouldn't say nothing to do with mental health services, but this is specific to our substance use disorder services programs.
So I would like, Jennifer has her hand raised. She probably could do a much thorough explanation than I can, so.
So to make it really complicated, the drug Medi-Cal organized delivery system waiver is broken between the 1115 and the 1915B waiver. So the bulk of the organized delivery system is in the 1915 waiver, but the element involving the residential treatment is in the 1115. I would say for your purposes, it doesn't matter. It's the financing mechanism and the way in which the federal law works with that particular component involving the residential IMD issues. But the contract and the organized delivery system was transitioned out of the state's old 1115 waiver and is now in the 1915 waiver, along with your specialty mental health services. So they are combined in a single waiver with the state and the federal government.
Okay, I appreciate the clarification. I'll be honest, not 100% sure that that's clarified in my mind, as it's been a learning process to go through this and dive through some information and hopefully finding the right information as I've been preparing for this today. Where does all of this, is this a precursor? I know the 1115 has been around for quite a while. Is the actions we're looking to take today, is it a precursor to, I was just speaking to Director Metcalf about this, is this a precursor to Cal-AIM? Does Cal-AIM, when it goes into effect, have a change on how 1115 will be affected by that? Again, something I haven't completely wrapped my brain around, but I know that there's some major changes, and I believe July 1st, 2023 is when things are supposed to start, though it's more of an option and not an automatic, we have to do it. But I'm just kind of curious as to the impacts of a decision today with the upcoming changes that Cal-AIM look to make in the approach to mental health in the counties.
Sure. So the waiver authorities, both 1115 and 1915, refer to the sections of the Social Security Act at the federal level in which Medicaid programs are allowed to organize themselves. And 1115 waivers are known as demonstration waivers, which means that you go to the federal government as a state and you say, I'd like to show you something. And if you waive certain rules, our demonstration of that thing will save money and do some newfangled innovation things. And we've had a history of several 1115 waivers in the state of California. The ODS waiver was originally in that 1115 waiver. And then a few years ago, I was still at the department and we were transitioning into thinking about our next waiver renewal. And we said, we're going to take all of the things out of the 1115 that we can, and we're going to put them in 1915. It is a less burdensome waiver, quite honestly, from a state perspective in terms of federal compliance. Think of a 1915 as more of a form like where you're just checking boxes. Yes, I comply with this. Yes, I comply with that. Yes, here is my network, check, check, check. Whereas a demonstration waiver is much more intensive from you have to continually show the federal government that you're doing what you said. And so CalAIM is the moniker that we gave the waiver renewal, and it actually went into effect in January of this year. But it is a multi-year series of initiatives and program changes. There will be significant changes in the specialty mental health county-based programs as a result of CalAIM. So there's financing changes, there's medical necessity changes, but the organized delivery system was essentially lifted and shifted from the old waiver into the new waiver, and there was just a couple of modifications, but it is in effect today. And the thing that you are considering as a board is whether you want to take that option and go from a state plan county into an ODS county, and then you would be working with the state and partnership, or doing county, preparedness, depending on which model you choose. You would be working to hit kind of an agreed upon implementation date, and that could be January. The state typically likes January, but we also like July because that's the start of the fiscal year. So we try to add benefits and make big changes either in January or July of subsequent years.
If I may, I just wanted to add that it is in our best interest to look at July 2023 and looking at the 1915B waiver as the changes or what we're looking to adopt. Regardless of the model, the extensive work that has to be done in preparation, whether it be with partnership in regional or DMC ODS, would require about a year of approval. And so if we're really giving, it is a large, multi-level, deep system review of information that I myself get pretty lost in. But if we could focus on 1915B and look at July 2023, because that's when payment reform is due to take in effect, and some of the more significant changes with CalAIM.
Okay, I appreciate it. Do you mind if I ask a couple more questions?
Yeah.
One of the highlights to me for the changes is the fact that, and I know Todd's going to look at me with very wide eyes, Director Metcalf, is that it does the contracting for you with the providers. And I think that's something that would help us a whole lot to be able to focus on the actual care of patients and the work that we're doing. Another thing that I'm thinking about is the last week we had a review from EQRO, I believe,
Yes,
that said that you're doing 75% of the work with the patients that we see, or our community members that need our services, and this looks like it might be helping to expand that direct access rather than having to go through you, who then brings them to the provider because you've created contracts and you created that pathway to get them there. Am I understanding that correctly, that it might alleviate some of the services that you are currently rendering by having that direct access to a provider rather than having to go through you, which then has your people working?
regardless, we are still going to have to contract many of these services out. And April, correct me if I'm wrong.
No.
But because this will, whichever model we enter into will afford us expanded and enhanced services and allow us to bill the state to receive funds back, through Medi-Cal, we will still have to contract out. I mean, when I look at this, whichever way we go, I don't really see it changing much, at least from a provider perspective, other than we would be able to provide additional services. We, along with all of the providers.
So if I may, yes, to answer your question, there is an administrative lift that partnership will take with doing the direct provider contracts. But there is also an addition for serving our indigent populations that partnership will not manage, so we will still have to carry separate contracts to provide those services. So in some sense, we will have the resources of partnership to do some of those tasks that we are doing independently now, if we chose the regional model. But it doesn't alleviate us of having to not have separate contracts for those providers, or to go outside of the partnership network to meet those additional requirements. So as Jennifer alluded to, we don't get to negate or to not comply with the requirements. So we may have to carry a contract with someone in Southern California to meet the youth residential component. And so partnership, if they don't have that contract, we're still on the fence of making sure that we ensure that.
So it would minimize the number of it would lower the number of contracts, but not negate the entirety of it. You would still have to do those things on your own if you needed to. And I think that still helps. My last thing is, between the two potential pathways of the waiver, while I see from Dr. Gardner's emails that we all received that there seems to be excitement to aim towards the partnership health, in my opinion, I don't have enough financial understanding on the difference and how it affects your budget. And I know that I'm going to attempt your last name, Mr. Bontrager. Hopefully I got that right. He had offered to do a financial review, and I would love to see a financial review so that we can compare apples to apples and see which one is going to provide a better service and which one is going to provide us the funding we need to be successful in delivering the services we need. Because I hate to come back a year from now and have Director Metcalf come to us and say, can we please borrow some money? We're not able to provide the services. So that to me is a very sensitive point that I don't have enough information today to be able to say so. And I'd love to see if it's possible to still get that financial review.
And and Mark, I hope, are you still here with us? Yes, I see you.
Yep.
I think one of the unknowns here is that because the regional model is still somewhat new, that they haven't gone through a whole cost settlement process. So I don't, and Mark, please correct me if I'm wrong, I don't know if they have that information yet.
Mark?
Yeah, thank you. And it's Bontrager, but your pronunciation worked. It was fine. Quite honestly, I don't even know how material the financial piece is, because as Jennifer explained, I think the net, the final result is pretty similar regardless of which way you go. The federal and state participation or reimbursement is going to look similar regardless of model you choose. So I don't see this being a financial decision necessarily. I think it's one of is it significant enough to lower the administrative burdens to choose the regional model, or there's also the loss of some control too doing it that way. And if you have the internal capacity and the wherewithal, then maybe you go it alone. But as far as financing, and I'll defer to Jennifer, I believe what you can pull down from federal and state is going to look similar regardless of model. But I'll defer to Jennifer.
Yeah, I think what I was trying to make clear is that whichever model you choose, be it if you were to do the ODS on your own as a standalone county, you would incur the costs associated with the services for sure. But obviously, as I said, with the Marin example, you can really see how much federal money is made available. But the trade-off is that you may need to have more infrastructure within your county to do those administrative activities, right? So there's going to be some more contracting. There is the 24-hour kind of line in which beneficiaries can get access. there are some administrative things that you would incur, and those come with matching funds, right? Because you as a subsidiary of the state doing Medicaid work would be allowed to have those costs covered by a portion of those by the federal government. But some counties, in choosing the partnership model, have said, we don't want to create that county administrative infrastructure, and we would prefer to have partnership do it on our behalf. As Mark said, there is a cost associated with partnership administering that for you, but that really gets down into the very, very fine pieces of your county financing for what you pay for and support now versus what you would pay partnership to do that. I think generally they probably tend to be the same, but it also just depends on you as a county making a choice as to whether you want to really kind of own your own infrastructure and your own way of administering the program versus letting partnership do it on your behalf. And to be fair, it's partnership in partnership with their own vendor, right? Because I think Beacon does a lot of the actual contracting and provider management issues. Mark's shaking his head.
Yeah, the only role Beacon plays for us is to manage the 24-hour access line. We do
Okay.
the own contracting and that sort of thing.
Thank you for that clarification. So that's kind of the choice that the counties make, but the money should hopefully, if it doesn't net out to be about the same, then there's something wrong.
If I may, I just wanted to add, there is also room for counties to leverage support of county council in developing the contracts with partnership to call out some of those things early on if the regional model is the direction that is chosen.
Can you talk closer to the mic?
Yes, sorry. I'm not used to being asked to talk louder. I apologize. So there is an opportunity for each individual county inside of the regional model to leverage county council to negotiate those contract terms going into partnership in the regional, right? So what that means is when we talk about giving up local control, or we talk about the negotiated rates, or we talk about how counties are involved, right? There is room in the regional model to be able to negotiate those terms and conditions, but it will rely heavily upon each county and their council to really go into this contract negotiation. And Mark, please correct me if I'm wrong, but each county develops their separate contracts, and so we can call out some of the things that if we have concerns with partnership, we can call out some of those special provisions inside of that, correct?
As it relates to the regional model, partnership contracts with those providers directly on behalf of all participating counties. Now, counties might have a separate contract with that provider outside of the regional model if they choose to do so, but as it relates to the regional model, we hold the relationship with the providers. We contract with them on behalf of all 7 counties, and I think that's actually a strength. There's one relationship with the providers, and all of them are seeking significant increases, and so we have to manage that across the network. So we want to both support our providers and also hammer out a good contract with them as well.
Ms. Grant?
Then just for clarity, the overall agreement is essentially one agreement that's entered into for benefit of all the counties. It's not something that allows for leverage by my office or any place else to hammer out unique provisions.
Yeah, that tri-party agreement that I referenced before, it's between the state and the counties in partnership. That was created by the state, and that is kind of as is.
All right.
I guess so. I wasn't clear. I had reviewed some contracts online and I saw that specific counties had negotiated how processes were called out, referrals, different functions. And so I was referring to that, not necessarily our contracts or the contracts with the providers. As you mentioned, that is something that we consider a strength in the regional model. But more importantly, that when we develop a contract with partnership, each county, I review the contract separately. They do call out different provisions for each county. Counties can negotiate the terms of their agreement with partnership. And that's the thing that I'm trying to clarify. Are you saying that counties cannot do that, or they can?
Well, yes, there's nuances to each county, and so we do our darndest to accommodate that when possible.
And that would be what I was referring to as needing our county council for support in that direction.
Thank you. And so with that, I'm not seeing any other questions from the board, so I'll, unless you have something else, Ms. Colfax, go ahead.
Sorry, I just wanted to point out there was something that this part of this conversation brought up for me. One of the things we did repeatedly hear from our stakeholders, and this is not a bash toward our behavioral health program at all, but really one of the limitations we have here in the county is qualified personnel who can administer and provide services. And one of the things that was brought up repeatedly in our conversations was that being a limiting factor rather than, the capacity the actual capacity of providers available in our county to work on, to administrate these programs, that was really one of the primary concerns, because it's not something really new. It's something that has been going on for a long time. And so being able to focus behavioral health's work on clinicians and providers of services rather than on administrative functions allows us to focus. And that's one of the things, like I said, the stakeholders brought up repeatedly was the manpower behind it. And I agree with what I think, excuse me.
Supervisor Sabatier.
Yeah, him. I just resorted to calling you Bruno, I'm sorry. Referred to was that ability of our manpower to focus on where the needs are for our folks here versus being able to have the administrative support of partnership and having them take on the things that can be met elsewhere.
Well, thank you.
Thank you, Julie. Yes, I know you've heard me talk about the difficulty we have in recruiting, qualified, eligible folks to do this work. And I do just want to say, and that's why we're bringing this to the board, I've been having conversations around this for the last 5+ years. And a lot of things have changed over the last 5 years around the 1115 and 1915B waivers. And this is not about behavioral services having control over anything. This is about ensuring that we are providing the best services we can and maximizing whatever funding is available to provide those services. And so we are not attached to any particular model. We just want to make sure we're making an informed decision and to ensure that our community gets the services and programs that they need and deserve. Because as we all know, substance use disorders are a major issue in this county. And so we're looking at this as an opportunity, whichever way we go, to be able to expand and enhance the services that we are already providing and hopefully adding more.
Thank you for that. Thank you. And thank you for bringing a very robust presentation that has both sides of the spectrum that give us a real balanced and informed, presentation that helps us to understand both. I know some of it's confusing, even though I thought I knew coming into it, I knew about it. Yeah, but because now there's different things that mean the same thing, like regional and partnership. And so I'm just, yeah. So anyhow, if there's no more questions, I'll open it up to the public. Is there anyone in the chambers that'd like to say anything about this? And then, so come on up and state your name for the record. Joan, you'll be next. Joan, you'll be next.
Hi, I'm Lori Carter-Runyon, Hilltop Recovery Services. Sometimes they're devil's advocate. First, I'd like to say, I spent a lot of years battling behavioral health, and then I've spent a lot of recent years working with them and repairing the relationships to provide services in this community. But I'm a provider for both the regional model, partnership, and Lake County Behavioral Health. So I currently have 12 residents in partnership, and I'm waiting for my women's beds to expand to be able to have partnerships. So I have 12. I have 4 Lake County resident beds at the moment. The other funding that I get is through Adventist Health, probation, tribal health. I seek other funding sources because there's not enough adequate funding for placement. I have probably 10 men on screenings in my book right now waiting for beds for placements that I can't obtain funding for. My experience through COVID was that's when we went live for the regional model. We had a lot of support, a lot of communication. We do quality service review meetings every other month. Well, no, we do provider meetings every other month, and then we do quality assurance reviews with only providers and outside resources for partnership on a regular basis. The support that we've gotten, the infrastructure. So and Beacon doesn't have to be the one that calls, they have the no wrong door, which I've also been working with April on our 4 beds. We've just recently started that, but still it's only 4 beds. They're allowed to call us, like they said, they can come in anywhere. We do our screenings, we bring them in, we set up the times for them to come in. We can assess them if they need to go to a lower level of care or a higher level of care. We can actually, within the network, call other providers and let them know that they need, that they might need to go to, say, Waterfront, which is in Humboldt, because they have incidental medical services. This is all a part of the existing infrastructure that Partnership has in place with their contracts for the 7 counties. So right now, anybody that calls that's in the 7 counties can go to any of those providers in the 7 counties. It doesn't limit it. Lake County joining the waiver under regional model means that the existing contract providers they have are accessible for anybody in Lake County. Now, again, regional model or ODS, it doesn't affect Hilltop personally. And I've been, again, like their devil's advocate, it's about services. And the thing is, without a Lake County contract before, I've survived. Hilltop has survived. It's, it really is the fact that we don't capture the services that we need for Lake County residents in the residential, in residential care. Our intensive outpatient, unfortunately, it's too small right now since COVID. We used to have a lot more, access to services there in the continuum. Having the residential care for Lake County residents, being able to have them in the intensive outpatient and outpatient to follow through the continuum is going to increase success rates. That's not available in this community right now, except for a limited number. And that's what going regional model, who has the existing infrastructure, I feel would best provide for our community. And again, it doesn't affect, I contract with them, I contract with regional model, I contract with other providers. I can contract with Marin County. They've offered, other counties have offered. It's really about what our county needs. And I personally feel that the regional model has shown that they have the existing infrastructure and the network that they've helped. They do their quality assurance. They come in for their, for the visits, and when we struggle with something, they communicate with us, and they're on top of it. They did have a recent situation where their network system went down, and they stayed in contact with us the whole time. They worked through it. They were calling us regularly to see how things were. They provided technical assistance when we didn't know how to do things, and it's been really good because they have a large network. We're working with a smaller county agency that doesn't have enough people to address it. They do their best to provide the services, but it's not big enough. And the need is bigger and greater than what we have available. Even for us as providers, we don't have the need. We don't have the services. We don't have enough to meet the need of our community. And so having the option to go to other counties, and again, the contracts already exist. That network, that structure already exists. They have the detox programs, they have the incidental medical services, they have the withdrawal management. We work with other providers. We actually work with other providers to address the methadone when they're tapering for methadone or coming into this community on methadone, which we don't have a provider in Lake County for methadone. So the providers we work from in Solano County actually assist us in getting the methadone for the month for the individuals that are in treatment. It's all part of that existing network that exists, along with the fact that Partnership has partnership transport services, which is amazing. You call up anywhere that you're in those 7 counties and you schedule a ride, you let them know that it is necessary to get them to the appointment or they will lose their bed placement, and they will make it happen quickly. It's all part of that existing infrastructure they have. And that's actually an expanded service that doesn't even have to do with the 1115 waiver. That's something Partnership does. So again, I mean, I work with Lake County Behavioral Health. We have good working relationships. I work with Partnership, and my concern is the need of the community, and that's why I support the regional model. So,
Thank you.
thank you.
Thank you. Joan, did you want to come up? I seen you got up earlier.
Joan Moss. I am not an expert, but I wanted to say that one of my doctors, when he says hello and makes an appointment, he says, "We no longer have Partnership Health." And I was in his office and I said, "Why have you disconnected from Partnership Health?" He said, "Simply, they take too long." I mean, he didn't really go into it. But I'm wondering, this was for a totally different kind of medical care, but if you sign it and you try it, you don't like it, can you get out of it? That was my question, because you just never know what might happen.
Thank you, Joan. Go ahead, April.
I would like to ask Mark to respond to that because it's been my understanding that counties can negotiate a term date if they were to go into the regional model. So an example would be that they could try it out for 2 years. And I would like for Mark to provide feedback.
Yeah, I mean, it's my understanding that if a county would choose to opt out, they can do so. We haven't had that yet since we've gone live, but that's certainly possible. This is not a till death do us part kind of an arrangement. So there are some opportunities there, but I would imagine that one requirement would be that it's a full fiscal year or so we can go through a full reconciliation if someone would choose to opt out.
Thank you.
But of course, our contract boilerplate language does have a termination clause, which I would advocate that we would incorporate into a contract with Partnership Health Plan. And Ms. Grant, correct me if I'm wrong.
Ms. Grant?
Yes, the county tends to favor several of its own standard contract provisions.
Thank you. All right, if there's anyone else that has public comment, yes, come on up. And then, Zach, you can follow Dr. Gardner.
Good morning, supervisors and staff. Bob Gardner from Lucerne. I would just encourage the board to support and participate in ODS. The enhanced services are critical. They're going to save lives. They're going to help our economy. That part is hopefully a no-brainer. The part about who does the administration, the Partnership Health comment, I've served on their board as an appointed representative from our county. These guys are the most professional, well-organized, efficient group I've ever been in partnership with, I've ever worked with. They take 2/3 of the people in our county, 2 out of 3 people, they're in charge of the physical and mental part. It just seems sensible they would be in charge of the substance abuse part. Hard to separate people. As Jennifer Kent said about recreating the wheel, this is a lot of work. We're not Marin County where we have people from the city. We have this incredibly sophisticated labor pool. We have people, we're a sequestered little county. It's hard, I forget the percentage of jobs in behavioral health that are empty now. We don't have the pool to draw from. This is something that's, and not that I don't love you guys, you do a good job. This is way over the heads of a small local government agency. And I think it's important to trust the opinions of the local health professionals. The statistics you said, I had the same, I had a open survey. I got about 30 back. They were the health professionals. I didn't have anybody who wanted local government controlling this waiver. Everybody wanted partnership. They had good experiences with partnership. Not that government doesn't do good jobs, but I just believe established professional public nonprofits that have statewide business are going to do a better job.
Sure, 3 minutes.
Thank you.
Thank you. Next.
Good morning. My name is Zachary Ray, enrolled member at Scotts Valley Band of Pomo Indians. I'm also the executive director for California Tribal TANF Partnership, administered by Robinson Rancheria. We're the 4th largest Native American social services program in the nation, servicing 17 counties in Northern California, with our central office being here in Lake County. Behavioral health is a major issue that we see all across the board. The behavioral health department here is severely understaffed and underfunded. We're trying to hire a behavioral health manager for our program, and it's extremely difficult with them being housed here in Lake County. Whichever provider you end up going with, I would implore you to make sure that we have additional funding for our behavioral health department and make sure that we have more licensed professionals that are able to assist not only our participants in our communities, but all of our community members here, because mental health is a serious issue. All of the other symptoms that we see from substance abuse, domestic violence, those are all stemming from mental health issues that are going undiagnosed and untreated. And we need more resources in our community. And so whichever decision you go with, please make sure that we get more resources for our community members. Thank you.
Thank you, Mr. Ray. Anyone else in the chambers that has any comments on this? And I'll bring it to the Zoom room. Attendees, Victoria Kelly. You can unmute. You have 3 minutes.
Hi, can you hear me?
Yes.
Okay. Good morning, Victoria Kelly with Redwood Community Services. I first want to start and say thank you to Todd and April and the team at Lake County Behavioral Health. This stakeholder process and the individual meetings with providers, I know have been intense and difficult at times, but also much needed. There was some needed repairing and communication that occurred that I really just appreciate your willingness to forge through with us. And it has felt good to kind of get through that. As a provider of said services in Lake County, we have been watching and participating in the stakeholder conversations with intensity around what's going to happen. We are a provider for partnership in other counties and do serve other counties through the partnership regional model, and have had positive work and success with the women that we've served. And as much as I have seen the growth in our relationships with Lake County Behavioral Health through this time, I do think for RCS, we are hopeful that the board and the Lake County Behavioral Health team really sees the positives in shifting over to a partnership regional model ODS system, and moves us forward into that system delivery to engage and engage more Medi-Cal beneficiaries in the community, serving more, increasing access to services, and potentially even looking at opportunities to grow in-county services, so people don't have to leave our county to get much needed SEDS services, because when they leave, when they go, there's an example about going to out of county, treatment, and then having to come back, and coming back and not having the platform of services and the outpatient intensive services that are necessary to support recovery. It's not a model that's sustainable for our community. And so I hope that with moving into the partnership ODS waiver, we can then look at shifting the focus off administrative processes and looking at opportunities to actually grow services in county that are needed for our community. So thank you.
Thank you, Victoria. I'm not seeing any other hands up in the Zoom room, so I'll close public input and bring it back to the board for action and either further discussion or action. Supervisors, I'll have Vice Chair Scott go, and then since you've talked already.
Well, with everything we've heard and everything we know about behavioral health, we need to definitely be looking at ways to increase access for our community members. We know behavioral health is the keystone that's going to be solving lots of issues that we have here in our community. We do know we have a capacity issue with behavioral health here in Lake County, and I think we need to be looking at ways to broaden our resources. So I'm in support of going for the regional model.
Supervisor Sabatier.
Thank you. So quick question. Got the answer that there's not much of a financial difference between one way or another, but the difference between where we are today and what resources we're drawing from federal and state, it almost sounded like there will be a new influx of potential resources. Is it the same resources? Is it just that we lose a little bit of the control of those resources by working with Partnership Health and providing them that percentage? Can you describe the difference between what we're doing right now and what the changes would be for you? Again, I want to make sure that financially we're making the right decision, because it sounds to me like the services would definitely potentially benefit from working in a regional way and having access to the network that Partnership has and the administrative asset that Partnership would offer us. But I want to make sure financially where we're coming from and where we're going, what the difference would be.
I'm hoping that Mark and Jennifer, I see they're still here. I believe if we move into the regional model, we will lose some control. I know most notably around rate setting that it'd be more of a burden to collaboratively among the regional counties negotiate higher rates. The way we're doing it now, we would, if we contracted directly with the state, we would have a little more flexibility around that, but I'm hoping that Jennifer and Mark might help me out there.
Sure.
I don't want to misquote or misspeak.
Sure. So the services that we both talked about, both Mark and I, in terms of the additional benefits that are available under the ODS system, notably residential, but there's also recovery services, additional MAT, physician consultation, intensive outpatient treatment. Those are services today that if you provide them, you do not get federal matching funds for those. To the extent that you move into ODS, the state has said that they will pay for the costs associated with residential and IoT. The only thing that you have to pay for in the new model is the room and board, right? Medicaid funds cannot be used for that. So you actually are in a potential place in which things that you have been paying for today using your substance abuse block grant or other lines of funding, those can be freed up because the federal government will be providing those in support. I think that the concern around contracts, as Director Metcalf referenced, partnership would be taking that on. And this is where it really is a local decision. Do you want to have someone negotiating those contracts and those rates on your behalf because you think that is administratively easier? Or do you really want to retain that control as a local county function? And so I can say that there are pluses and minuses to both options. I know that 7 counties have chosen within the partnership model to have partnership administer that on their behalf, but other counties, so Napa, Marin, and Yolo have said, nope, we're good. We want to do it anyway. Even though we're in the partnership, we want to run our own thing. And so this really is a, how much of it do you want to be owned and controlled by your local county and by your staff versus how much do you want to cede to partnership? And I don't mean that in a bad way. It's just a choice that you are being asked to make.
And I'd like to clarify my question again. The resources that we're currently obtaining from the state and federal, do we get a new influx by waiving this, is what I'm hearing? Okay, so it's just a change of operations, but also another benefit is that you get to access some extra funds. Okay.
Correct.
One last question. It was brought up by, I believe, the Hilltop Recovery public comment that we received about the transport. I know that we've been dealing with transports a whole lot and that we do not get repaid. There is no code to submit for repayment of the transports. Will that help us in that, or is that completely separate?
Well, they're actually one and the same. Again, this is just speaking to our substance use disorder services clients. Those interfacility transfers to which you're referring mostly pertain to our mental health clients. But you are correct, and you've heard me say before, we do not get reimbursed for staff time to transport clients.
But if you happen to transport substance abuse folks today, you would struggle to get repaid, but through this, there may be that extra
In the
added
partnership,
benefit.
yes, in the
I
regional
think
model,
is an awesome add-on in comparison to right now what we have. So
Oh, yeah.
I wanted to ask that question, and thank you for the answer.
Supervisor Pyska?
So I think it's a wonderful opportunity for us to be leveraging our resources and having the access with the regional approach. But can you, Director Metcalf, just speak on how that will affect the capacity in your department?
Well, I'm hoping it will allow us at least more access to more services amongst the other counties that are part of this model.
Right, but with your staff that you have currently and their workload.
We don't see, and April, correct me if I'm wrong, we don't see that it would be a major impact to us.
Okay.
No, may I comment?
Yes.
So, something that wasn't mentioned as far as the entitlement and services that become available to counties, regardless of the model, is case management. And case management is something about collaboration and really coordination of care, right? So one of the perspectives is that we now get paid for our time in communicating and coordinating placements as they transition through what is referenced as a golden thread. So when they move in and out through levels of care, right? So when it comes to capacity issues within our department, I don't see it having a negative impact on our ability to retain the staff that we have. I see it as expanding resources and leveraging other resources with others providing case management services. So partnership can provide case management in their case management frameworks, or counties can locally develop case management. So there is a potential to increase capacity within our department to expand on case management or outpatient services. It is also imperative that we as a county collaborate with our partners to ensure that we are part of that continuum of care, so that when they're referred to Hilltop or to another regional county for residential placement, that they come back to our services or to another provider of that same level of care inside of our county, right? So I think that it relieves a little bit in that we leverage other resources with providing those services, but it also increases our ability to expand capacity in those direct services that we're wanting to provide.
Great, thank you.
And Elise had her hand up, Elise Jones, and I know Director Metcalf, you had mentioned she might have some input. So Elise, if you can unmute and give your insight.
Thank you, Chair, and I apologize in advance for any background noise. I'm actually supposed to be off sick today. I was up all night with my son. However, I wanted to make a couple of points, and last week when we presented on the external quality review report, I want to clarify that that was specifically for a mental health program. And by joining the waiver, this is another step towards parity between mental health and SUD services, and hopefully parity as a whole with healthcare. And so parity continues to me to be a significant driving force with regard to the expansion and provision of services. My dream, I guess I'll digress a little bit, is that behavioral health, it has the same reimbursable rate and the same clout, for lack of a better way of putting it, as any other type of healthcare. Now, mental health is subject to network adequacy standards, which means that we must maintain a certain level of full-time equivalent employees to meet what the federal government has determined to be the needs of our community. Now, the ways by which they conduct that assessment are somewhat arcane and unknown to me, I'll be honest. However, they do come down and they say, this is what you must have, and they evaluate and they prescribe the FTE of psychiatry and other staff that we have to meet those network adequacy standards, and we are held liable by the federal government if we don't meet that. By joining the ODS waiver, we are also now subject to the EQRO requirement and also to these network adequacy standards. So that would be true regardless of the model into which we went. And therefore, regardless, we would still be held to the same standard of NACT of having so many FTE for various levels of care. Regardless, we would be obligated to maintain that and to provide that. Again, the only significant difference here, as has been iterated, is that we maintain local control of those resources and have more of a hand in developing and growing those local resources. And I am incredibly proud of our department for having been able to provide uncovered services under the traditional DMC plan through creative use of our grant funds. And so either way, it's an incredible opportunity, but I did want to point out that we are beholden to those same NAC standards regardless of the model in which we join. Thank you.
Thank you. Any other comments? All right. With that, it looks like we're at a point where we can take action. And from what I understand, approved joining the ODS is its own separate, and then following that would be which model we go with following. So, yeah.
Mr. Chair, I move to approve joining the organized delivery system.
Second.
All right. So I have a motion and a second. All in favor?
Aye.
Opposed? Motion carries. And then item B, vote on joining either DMC ODS or regional model ODS.
Mr. Chair, I move to join the regional model ODS.
Second.
So I have a motion and a second. All in favor?
Aye.
Opposed? Motion carries. And so that means we're now going in the direction with the regional model, and we'll look forward to seeing how that goes. And thank you for your presentation. Thank you for everything.
Thank you. I know this is very complicated. It's been equally complicated for us as
But I know
well. So
more
we
about it.
appreciate your support in this. And yes, there will be updates to come.
Thank
So,
you.
Thank you.